Hi everyone. So today our discussion will revolve around methods for analytical intercategorical intersectionality in quantitative research, specifically taking a look at Greta Bauer, Aidan Shimes' paper. And our group is Masha, Ellie, Rashid, Lance, Vicky, and Ankita. We'll begin by speaking to the theory and development of intersectionality, as well as the public health relevance, before delving into the model, implications, and finally the limitations and future directions to orient us for the discussion. So before going into the theory in the paper, we're first going to briefly take a look at how intersectionality has been used to shape and analyze encounters in the clinical sphere on both the epidemiological scale and the more granular patient-doctor interactions. I know we've all explored intersectionality in doctoring, so hopefully this can build upon that framework. So we can take a look at the extent to which quantitative intersectionality can capture forms of inequality. And I'd like to preface by saying that aspects and the language of intersectionality necessarily include categorization of populations, which have both strengths and limitations that we'll further explore in the discussion. Let's start off with a hypothetical clinical encounter. Mr. Fuentes is a 36-year-old construction worker from Central America with chronic lower back pain. He's gone to numerous urgent care centers seeking pain relief from back spasms and now presents to a primary care clinic that accepts walk-ins. The doctor who examines him, Dr. Roberts, prescribes a muscle relaxant. When Mr. Fuentes remarks, "Can you give me anything stronger? I've already used this medication and it makes me sleepy but doesn't help the pain." Dr. Roberts worries that Mr. Fuentes may be seeking narcotics. Hesitant to prescribe opioids, Dr. Roberts suggests that physical therapy may be a more appropriate intervention and sends a referral. Mr. Fuentes leaves the encounter disappointed, wondering how he is going to get through his next day on the job without worsening pain. So here we can see how converging issues of structural disadvantage and ethnicity can better inform this interaction. An intersectional lens notes that, for example, racial ethnic minorities such as Mr. Fuentes are disproportionately employed in, quote, blue-collar jobs that are physically demanding, pay less, and are accompanied by less insurance coverage. Also, while doctors are now pressured to be more cautious in prescribing opioids given the significance of the opioid crisis, African Americans and Latinos are more scrutinized for drug-seeking behavior compared with whites, despite having drug use rates similar to those of whites. Mr. Fuentes doesn't have consistent care or a clinician who can vouch for his chronic pain. And so Mr. Fuentes' request for opioids leads Dr. Roberts to offer a referral instead of adequate pain medication. So this next example takes a look at how intersectionality is used epidemiologically. So in this statement, back in 2005, the infant mortality rate for Black women with more than 13 years of education was almost 3 times higher than that for non-Latino white women. So there's a vast array of public health literature that describes the correlation between higher socioeconomic status and better health outcomes. People argue that intersectionality can provide an opportunity to nuance these empirically based statements that ultimately affect, clinical relationships, public health programs, policy, etc. This demonstrates, the statement demonstrates what is called intersectionality paradox, which describes health outcomes at the intersection of high status identity, such as middle socioeconomic status, with race and gender for Black middle class women and men. Historically, the infant mortality rate of highly educated Black women has exceeded that of non-Latino white women with less formal education, highlighting the paradox of the intersection of socioeconomic status, race, and gender for Black women in the U.S. So we can see how intersectionality does not really assume equally distributed disadvantage across identity, but rather how high and low status social identities intersect to yield disparity and advantage. So, as we've learned and explored in our doctoring sessions, intersectionality really asks us about the ways that categories like race, gender, sexuality, and class interact with one another and shape our own sense of self and of how we interact in the world. So, it's not just this analysis of identity and experience, but it provides a conceptual framework to understand power dynamics. In other words, we can ask, how do existing power structures exclude and make certain people more vulnerable than others? And as we'll explore in preceding slides, intersectionality uses matrix effects rather than linear additive relationships to both add complexity and clarity to power dynamics. The idea of intersectionality is not a new one. Understanding and analyzing these interactions of identity and experience emerged from Black feminist scholarship, and legal scholar Kimberly Crenshaw was the one to actually term it. Since then, the framework has expanded to look at numerous power dynamics of oppression. Of note in the development of this intersectionality framework is Havinsky's conceptual and intersectional shift, in which he calls on researchers and clinicians to not only utilize intersectionality to understand these matrix effects of identity and power dynamics amongst patient and participants, but to, quote, reflect on the complexity of their own social locations, how their values, experiences, and interests shape the type of research they engage with, including the problems they choose to.
To shift these ideals back to a public health framework, we look to Lisa Boleg, who is a social psychologist at GW, whose work focuses on intersectionality in public health. Specifically, she focuses on how social contexts of stress and masculinity affect the health of Black LGBT people. She describes intersectionality as having four main characteristics important to public health. The first and most straightforward point is that social categories are not independent or unidimensional, but multiple, interdependent, and mutually constitutive. Secondly, it is important to note that intersectionality places importance on intersecting identities that have been historically marginalized or oppressed. More specifically, the health of these populations is examined in their own vantage point rather than through the deviation from the norms of white middle class people. Similar to the discussions we had in doctoring about placing emphasis on the social structures at play, intersectionality looks at how multiple social identities of an individual's experience intersect with multiple level social inequalities at the macro structural level. One of the largest challenges with intersectionality in public health is the ability to complete quantitative research. Because of the multidimensionality of intersectionality, it is important to move away from a linear additive model and into a model that captures the complexity of multiple social groups within and across intersecting analytical categories. This brings us to our paper of discussion. In this paper, the author's purpose was to create a new way of analyzing social and structural data in order to capture the complexity of intersectionality. This is extremely important as numbers have weight, so having the ability to complete these complex analytics makes these studies much more translatable for biomedical research. Bauer describes using an intercategorical approach rather than an intracategorical approach. The best way to explain this would be looking at intersectionality as a common intersection of multiple axes rather than an overlap, as in a Venn diagram. As mentioned before, it is important to look at this framework as avoiding describing the intersection as a sum of parts, but rather the interactions occurring in different directions. Bauer describes four characteristics of their quantitative analytic approach to intersectionality. Focusing on the power differential that comes from these differential structural interactions, using a descriptive approach in the start to ensure a holistic understanding of the processes and interactions at play, the use of these models to consider the contributions of causal processes to intersectional inequalities, and lastly, it is important for methods used to estimate the effects of these causal processes to allow for variation in magnitude, direction, and existence. The authors start with a basic view of mediation analysis, where instead of just conceptualizing how a specific intersectional category leads to a health outcome, they look at how there might be a mediator leading to these outcomes, such as discrimination or oppression. This is in line with the characteristic of describing social structural outcomes through the power differentials that affect these categories, as well as with the characteristic of understanding the causal processes underlying these health outcomes. Additionally, as shown with the gray lines, they account for changes in direction and magnitude.
Now that we've talked about the important assumptions for mediation analysis, I'm going to summarize the math behind the three-way decomposition that underlies this analysis. First, it's important to understand the term TE, or total effect. This is the difference in health outcome between two groups, labeled 1 and 0 here. We are taking group 0 to be the reference group and group 1 to be the group of interest. So here, Y1 is referring to the health outcome of an individual in group 1, and Y0 is referring to the health outcome of an individual in group 0. We can also write these terms Y1M0, Y0M0, Y1M1, and Y0M1. The M1 or M0 corresponds to the level of discrimination an individual in group 1 or 0 experiences respectively. And Y1 or 0 with the M in the subscript refers to the health outcome of an individual in group 1 or 0 if they had experienced the level of discrimination M0 or M1. So explicitly, Y1M0 corresponds to the health outcome of someone in group 1 who had experienced the discrimination of someone in group 0. Y0M0 corresponds to the health outcome of someone in group 0 who had experienced the discrimination of someone in group 0. Y1M1 corresponds to the health outcome of someone in group 1 who had experienced the discrimination of someone in group 1, and so on. Note that while Y0M0 and Y1M1 are things we can observe, Y1M0 and Y0M1, which hasn't come up yet on the slide, are counterfactuals, or things we cannot observe. We will talk a bit more about counterfactuals later on. So we can write Y1 and Y0 from the total effect equation as Y1M1 and Y0M0. And then, if we add the expressions for the pure direct effect and total indirect effect together, we see that the Y1M0 terms cancel out, and we get the total effect, Y1M1 minus Y0M0. Okay, so now we understand all the variables and why we can do this decomposition. We might wonder why we would want to do this decomposition, or how this decomposition helps us. And so, in order to understand the effect of the mediator, in this case discrimination, on health outcome, we first need to recognize that the difference in health outcomes could come from something discrimination related, or from something not related to discrimination but intrinsic to the group. So we decompose the total effect into what is called a pure direct effect and a total indirect effect. The pure direct effect corresponds to the difference in health outcomes for a person in group 1 versus group 0, had they been subject to the discrimination of group 0, the reference group, regardless of what group they actually belonged to. We see this written as Y1M0 minus Y0M0. This is the part of the difference that's not related to discrimination, but about some other aspect of the group, because we're holding the discrimination part constant. The total indirect effect, then, is the part that can be attributed to discrimination. Explicitly, is the difference for an individual in group 1 had they experienced group 1 discrimination or group 0 discrimination. Here, we're holding the group identity constant, but changing the discrimination. Now, this is all a bit abstract, so Ratchet will give concrete examples in a little bit, but we will continue with our decomposition. So the total indirect effect can be further decomposed into a pure indirect effect, or PIE, and a mediated interaction term, or INT-MED. We can do a quick check that adding up these two terms does indeed give the total indirect effect, since the Y0M1 and Y0M0 terms cancel out to result in Y1M1 minus Y1M0, which is the expression for total indirect effect. The pure indirect effect corresponds to the difference for an individual in group 0 subject to the different levels of discrimination. This is a little bit different from our total indirect effect, which was a similar concept, but for an individual in group 1. The reason for this nuance is that individuals in different groups may be affected to different extents by the discrimination. This complicated interaction is called the mediated interaction, or IntMed, in this model. And it's basically the difference between how individuals in different groups are affected by discrimination. Note that this expression can also be rearranged to read y1m1 minus y1m0 minus, and in parentheses, y0m1 minus y0m0, which may be an easier way to see how it relates to what I described as the mediated interaction. In order to visualize a little bit easier what each of these terms correspond to in the diagram, we highlight them. So the PDE in red is just the arrow directly from A to Y. The PIE in yellow is the arrow directly from M to Y. And the IntMed contribution in green are the gray arrows and their effect on Y. Now, we briefly mentioned this earlier, but these three variables, PDE, PIE, and IntMed, are actually counterfactual quantities. This means that they cannot generally be observed, they're hypotheticals. An example is that we cannot observe the outcome if an individual belonging to group 0 had experienced a discrimination from belonging to group 1, or vice versa. This is similar to the idea that we cannot observe both treatment and control in the same person, which is why we need randomized controlled trials. So counterfactuals include the terms y1m0 and y0m1. And if you recall, all three terms contain at least one of these variables. So we cannot get PDE, PIE, and IntMed directly for individuals. However, under the counterfactual independence assumptions discussed earlier, we may be able to estimate them on average using regression techniques.
In the next few slides, we'll be discussing some of the primary outputs of this approach and what each of them represent or indicate. We'll first be giving the general definition and then the definition in the context of one of the previously mentioned examples, specifically the discussion of infant mortality due to a mediator of discrimination for women from different racial or ethnic backgrounds at different levels of education, where education was used as a measure of socioeconomic status, or SES. We'll be using high SES black women as one of the comparison groups and low SES white women as the reference group, though different groups could certainly be selected for these comparisons. The first output described, the pure direct effect, or PDE for short, is a measure of what the outcome for any one group would be if that group experienced a mediator at levels equal to that of a reference group. In the context of the example of infant mortality, this would be represented as the level of infant mortality that would be expected in high SES black women if they, as a group, experience the same amount of discrimination as low SES white women. If statistical testing of PDE showed significance, this would indicate that high SES black women would have different rates of infant mortality, even if their levels of discrimination were equalized with those of low SES white women. The second output described, the pure indirect effect, or PIE for short, is a measure of what the outcome for any one group would be if the actual magnitude of the effect of the mediator was the same for a tested group as it was for a reference group. In the context of the example, this would be represented as the level of infant mortality that would be expected in high SES black women if discrimination impacted the outcome the same way as it did for low SES women. This is a difficult topic to think about, so let's consider a more specific situation. If high SES black woman experienced twice as much discrimination as low SES white woman, then if the magnitude of the impact of discrimination were the same for both, the effect of discrimination on infant mortality should be exactly twice as much. To contrast, consider a situation where discrimination has twice the impact for high SES black woman as low SES white woman, and that the level of discrimination for high SES black woman is still double the levels. In that case, the expected impact overall would be 4 times as much, even though high SES black woman experienced twice as much discrimination because of the doubled magnitude of impact. If statistical testing of PIE showed significance, this could indicate that high SES black women would have different rates of infant mortality compared to low SES white women, attributable to differences in level of discrimination, independent of the impact that that discrimination itself has. The third output described, the mediated interaction, or INT-MED for short, is a measure of how much more or less a mediator affects a tested group in comparison to a reference group. In the context of the example, this would represent the magnitude of the impact of discrimination on high SES black women compared to low SES white women. If statistical testing of INT means showed significance, this would indicate that the infant mortality of high SES black women is differentially impacted by discrimination than the infant mortality of low SES white women. So, what exactly are the benefits of mediation analysis? One might ask, why would you do this instead of just coding each intersectional group as a separate group and then testing for differences in the outcome for each group? Well, the primary benefit of this particular type of mediation analysis is identifying whether the differences between two intersectional groups is due to the level of the mediator or due to the impact per unit of the mediator. For example, if one group faced 75% as much discrimination as another group, without considering how much discrimination affects that group, one might incorrectly conclude that intervention is not as necessary for that group, even if it may be important, like in the circumstance where discrimination has twice the negative impact on that particular group. When considering more traditional analyses like ANOVA or t-tests, which may help indicate the influence of a single dimension of intersectionality, like just race, ethnicity, or gender, those can typically help in determining that there exists a differences between groups in the first place without necessarily elucidating why that is the case. If intersections aren't found to be significant in these types of analyses, that may be due to the dual impact of intersectionality on the levels of a mediator as well as the magnitude of a mediator, and so these kinds of analyses can be helpful in finding those differences even in the circumstance where the output appears to be identical. I want to take a brief moment to talk about how knowing these kinds of differences in levels of a mediator versus the magnitude of impact can be important when considering policy or advocacy. For example, it can often be politically expensive or controversial to advocate for initiatives that reduce levels of discrimination, but it may be less challenging to advocate for initiatives to help reduce the per unit impact of that discrimination. For example, developing support systems. And so this is something that I might want you to consider for discussion, thinking about these topics as they might come up in your own research and how you can use novel analyses to try to identify possible areas of improvement.
So now we've discussed our methods in depth, let's switch gears and discuss the dataset authors used to illustrate the method, as well as talk about its limitations. Data for example analysis came from a survey created to validate intersectional discrimination index. The data obtained was collected online from 2,583 participants, which were awarded the monetary compensation or air miles. The author broke down a dataset with exposure consisting of 6 ethno-racial categories, as well as cross-stratified it by 2 sexual and gender minority categories, which are heterosexual cisgender or non-sexual gender minorities and sexual and gender minorities. At the end, authors had a total of 12 intersectional groups. The outcome was psychological distress, and exposure was membership in intersectional category, with perceived day-to-day discrimination as a mediator. As a result of application of the methods designed by Bauer and Scheim, authors found out that highest level of psychological distress was observed for indigenous and Middle Eastern SGM groups, which differed from other groups significantly. All SGM groups had higher level of psychological distress than non-sexual and gender minority groups. For example, Black sexual and gender minority group had higher levels of psychological distress than Black non-sexual gender minority group. Assuming all the assumptions are met, pure direct effect can be interpreted as residual causal intersectional effects on psychological distress if levels of discrimination were reduced to that of white non-sexual and gender minority group. Pure indirect effect, or effect due to mediation, which is discrimination in the study, was positive and significant for all groups except Asian non-SGM, signifying that there is actually a relationship between discrimination and psychological distress. To summarize the findings of the study, authors conclude that highest level of psychological distress is actually observed by 2 intersectional groups that are rarely studied and are rarely a focus of any intervention designed to improve health outcomes, which are Middle Eastern sexual and gender minorities and indigenous sexual and gender minorities. And the excess day-to-day discrimination they experience has adverse effects on their health outcomes. And the main effect comes from unequal level of discrimination based on their different group membership, which also offers great potential for intervention based on results. However, we must consider limitations of the study very carefully. So I want to talk about bias.
which affects a lot of studies. And the bias happens when the population we study is not necessarily equal to the target population. And since we draw conclusions on the population studied, we can't really apply them to the target population, like you can see on this illustration here. Just because your sample has red and yellow dots doesn't mean purple, blue, and green dots do not exist. Unfortunately, statistical theory assumes that we have a random and unbiased sample of the population under study, so statistics cannot really fix bias in the design. So the sample that authors use to validate their methods actually consists of a non-random sample that was derived from that online survey. And the problem with non-random sample, we still have selection bias because they only were able to reach the people who took that online survey. And another problem is social desirability bias, because participants might not be willing to answer truthfully or be willing to report fully, which also leads to measurement error in our data. Here you can see a good illustration of selection bias and measurement error in comparison to real data based on telephone surveys. So in real data, we would have people who are not willing to answer the phone. There will be people who are honest in telephone surveys, and there are people who lie in telephone surveys. If we have selection bias, we already exclude people who actually do not take those surveys. And if we have measurement error, we only end up with people who we think are honest in telephone surveys, which leads to measurement error. And another limitation of the study is the DAGs and confounders that authors use, which are rather broad. A good example is their immigration category. They had categories like immigration / temporary resident or citizen from birth. But that immigration category could also be broken down into legal and illegal immigrants, because that would lead to different day-to-day discrimination levels, which would affect the mediator that was very important in this study. Same goes with sex assigned birth or physical and mental disability. Those categories seemed rather binary, and they are not. Another problem with the study is competitive mediation, since discrimination can be different based on two groups that individuals identify with. Yes, they belong to a certain intersection, but, for example, Black, non-sexual, and gender minority status appear to have protective effect on the outcome. So such mediation between belonging to a Black group and non-sexual and gender minority group, it complicates interpretation of the study as well as intervention planning. And implementing interventions based on this study could lead to interventions based on mediator or outcome. So after we discussed the methods, their limitations, and discussed the study that authors used to test the methods, we identified a few potential future directions for the paper. First, there is definitely a need for more studies to identify other mediators that affect health outcomes, and maybe choose less broad confounders. Then there is better intervention planning and identifying risks and benefits of such interventions. And we want to avoid stigmatizing marginalized intersections as a result of these interventions, and we must try to avoid harm. And lastly, identifying strategies to remove health and social inequalities between intersections.